general surgery resident, originally from Los Angeles, California. Completed her bachelor's degree at the University of Washington and medical doctorate at Oregon Health and Science University. She was introduced to trauma-informed care as a medical student through work on a trauma-informed care instructional competency coursework and in designing a course for surgical interns. As a resident, she has been involved in the American College of Surgeons trauma-informed care curriculum since her first year in residency. She plans to pursue a fellowship in trauma and surgical critical care after residency. If I didn't botch all of that, without further ado, our presentation by Dr. Hernandez.
Thank you. Let me go ahead and share my screen here. Great. Hopefully everyone can see the screen. I am so excited to speak today. Thank you so much for this opportunity. So again, my name is Alex Hernandez. I'm a PGY4 general surgery resident, currently a research fellow at the Surgical Outcomes Research Center. Thank you for the opportunity to present part of our curriculum on trauma-informed care and highlight some of our work that's being done from the American College of Surgeons at Harborview Medical Center and other trauma centers across the nation. At the beginning, I want to state that I'm not an expert in trauma-informed care. As Carrie mentioned, I came to this work through a strong interest and through some amazing mentors as a medical student, and am passionate about integrating this into surgical practice and into care for injured patients, which is how I became part of this project early in residency. I would also like to acknowledge that these slides are the product of the American College of Surgeons and amazing Harborview faculty and team members from whom I have had the pleasure of working with, including Shelley Weishman, Amy Sarsoda, and Rebecca Main, to name a few, as well as Dr. Biscard, who is a current trauma surgical attending at Harborview Medical Center. Many others have also worked on this content and provided invaluable insight, and for that, I thank you. This curriculum was produced by a working group at the American College of Surgeons Committee on Trauma called ISAVE. This stands for Improving the Social Determinants of Health and Attenuating Violence. You gotta love those fancy acronyms. They developed this curriculum in partnership with the Institute for Nonviolence out of Chicago. Their primary initiative is to address root causes of violence with special attention to social determinants of health. So all this to say that this curriculum is through a lens of trauma surgeons with a special attention to violent injury. So that's predominantly the background that we're working with. This curriculum as a whole is a committee objective and part of an effort to train trauma centers nationally in a trauma-informed approach to prevent re-traumatization of our trauma patients. At Harborview, full training consists of a modified 3-hour session with the first hour on defining trauma and trauma-informed care, a second hour on vicarious trauma and identifying resources for providers and staff, and then a final hour on social determinants of health and the beloved community, as well as a community member piece to really ground this framework in the patients that we serve. This is the full curriculum, goals and objectives. So for the first hour, we typically cover the first 4. In the second, we talk about vicarious trauma and the resources that are listed here. And then in the final third hour, we cover these final 2 objectives to ground our training in the Harborview community. As I mentioned, this typically takes about 3 hours. So today we're going to be doing a shortened version and focusing on the didactic portion of this curriculum, because what we have in the in-person sessions are a number of kind of group work and working through scenarios. So we'll be omitting that as well. So these are today's goals and objectives. I'd like to define trauma, the impact of adverse childhood experiences and manifestations of trauma, review the SAMHSA framework for trauma-informed care and identify characteristics of trauma-informed care, talk about ways to render appropriate support, and then define vicarious trauma and talk about systems of provider support that are necessary for the success of this framework. I think it's important to establish a shared definition of trauma. I think that if you Google this, you will find a wide array of definitions, but this is the definition I'd like to ground this training in. Trauma results from an experience that is physically or emotionally harmful or life-threatening, that results in long-lasting adverse effects on a person's well-being. So this is much more than just physical manifestations of violence and injury. Trauma in this context includes adverse childhood experiences, or ACEs. Examples of ACEs are community violence, having an incarcerated family member, domestic violence, displacement, houselessness, and alike, all occurring during childhood. ACEs are positively correlated with numerous health outcomes. To name a few, substance use, heart disease, obesity, and liver disease, but honestly, the list truly goes on and on. We see these long-term impacts in many of the patients we serve. Many of these traumas that we term ACEs in childhood also affect people throughout their lives. In this process, I learned a lot about our Harborview patients, and taking our Harborview patient population as an example, our patients have on average 4 prior lifetime major traumas that occurred before the inciting traumatic event leading to their hospitalization. Many of our patients are functioning in a space of chronic traumatic stress, and it's important that we recognize the prevalence of trauma in our patient population, which is quite high. So what is a normal reaction to a frightening situation? You experience external threat, your fight or flight activates, your sympathetic nervous system upregulates, your heart rate goes up, adrenaline flows, blood flow to your arms and legs increases as you prepare your body to either run or fend off an attacker. Your hypothalamus triggers this sympathetic response and is augmented by the amygdala, which mediates your emotional response to fear. This is largely a primitive response, so your higher order functions are down-regulated, like your decision-making skills or the analytic part of your brain. When that threat is removed and you return to a state of safety, you return to this resting state, your fight or flight should be down-regulated, and once you experience safety. But what happens if you never actually reach safety? With repeated exposures to frightening and dangerous situations, the fear response, it never fully shuts down. And this person is functioning in a state of low-level panic on a constant basis. This clearly is going to impact reasoning, right? It creates attention bias towards potential threat, chronic anxiety, and hyperarousal. It increases levels of stress, which can take a physical toll, as we all know, and can cause difficulty processing new information and problem solving. This can be a barrier that we experience in healthcare, trying to get your patient to follow up or follow through or adherence to a medication plan. Goal-directed behavior becomes stay safe at all costs as the only objective. Trauma's impact on relationships can make it difficult to use appropriate interpersonal skills, develop strong bonds in relationships, and appropriate coping mechanisms, because interpersonal situations can feel high risk for traumatic stress to someone with this background, even if it's something that we would perceive is not high risk. Ultimately, this leads to toxic stress. This happens when someone does not have the resources or relationships to buffer this persistent activation of the stress response. Toxic stress negatively impacts learning, brain development, mental, and physical health, and it can lead to maladaptive behaviors in an effort to cope. Keep this in mind. We're going to come back to it a little bit later on. Trauma extends beyond individual events, as I mentioned, ACEs, and includes concepts like historical trauma or the cumulative emotional and psychological wounding over a lifespan or generation, and complex trauma, which represents the cumulative effect of repeat severe traumas on an individual. Our response to meeting patients who are experiencing this level of toxic stress or are in a state of low-level panic is trauma-informed care. So what exactly is trauma-informed care? This term gets thrown around a lot. I like to think of trauma-informed care as a strengths-based framework that's grounded in an understanding of and responsiveness to the impact of trauma. It emphasizes physical, psychological, and emotional safety for patients and providers, and creates empowerment for survivors to build a sense of agency and control. It's a universal framework, and it's been applied in the criminal justice system, other medical specialties like OB and pediatrics, but it's not frequently discussed, or not a frequently discussed concept, at least in surgery. When I think of trauma-informed care integrated into my clinical work, it's the practice of acknowledging that many of the patients we serve have histories of trauma, like I said, 4 lifetime traumas before their hospital admission. And the hospital environment, operating room, and often emergent and urgent demands of the way we practice can re-traumatize patients and elicit trauma responses to something that I would see as an innocuous action. If trauma causes a lack of predictability, loss of control, and lack of perceived safety, our role as a trauma-informed institution is to provide a setting that can contrast these negative experiences. To reduce medical trauma compounding on patients' prior trauma history, I encourage you to take a moment to think about the traumatic aspects of medical care that we see as routine care. We put an order in Epic, and then these things happen. I'm talking about things like IV sticks, Q2-hour vital signs throughout the night with repeated abrupt awakening for patients, and also exposure. Who's in the room when we're performing a sensitive exam, exposing a patient in the trauma bay, or during a morning physical exam? Pulling a gown up from someone's knees to their chest can be very triggering. So restoring a sense of control by offering choices in care when we're able to, and many of these things that I just listed are very malleable. We can change these things to make a patient more comfortable and accomplish our goal of providing excellent medical care. A number of hospital events, aside from what I just mentioned, can be perceived as traumatic. So exposure to other patients' harmful or painful experiences is a big trigger for some people. At Harborview, almost all of our hospital rooms are shared, and many of us have had the experience during high census times walking through a hallway where curtains are separating patients from people doing their clinical work and walking to and fro. Uncontrolled pain also has been linked to later development of PTSD. Here, we need to work hard to control pain up front to prevent this later burden. Also, painful rehabilitation or surgery is a very common pathway for injured patients. Severe disfigurement or permanent functional impairment. Traumatic injury can often be the most impactful event in someone's life and can lead to a lifetime of disability after a moment of crisis. At times, the care we provide can be physiologically perceived as traumatic. It's important to note that trauma reactions depend on the perception of threat. So actions you perceive as non-threatening may be experienced as traumatic by another. Recognize that the very care we intend to provide can be misconstrued as a source of potential harm from a patient. This brings me to our response. The Substance Abuse and Mental Health Services Administration model for trauma-informed care. I'm going to be referring to it as SAMHSA from here on out. So this brings us back to the definition of trauma again. So the 3 E's of trauma coined by SAMHSA are the event, the experience, and the effects that define a true trauma. Taking a step back to our original definition, an event or series of events that an individual experiences as physically or emotionally harmful that has lasting adverse effects on function and well-being. These are 3 critical components. Not every event is going to trigger a physical or emotional experience of harm, and not every negative experience from a traumatic event is going to result in long-term effects. All events are also experienced differently. Something may be experienced as traumatic for one person and not for another. So an important component of this experience is a loss of agency or control. Effects can be immediate or have delayed onset. Overall, effects are very broad and are not limited to this list. Trauma can take many forms. Something that I think everyone is very familiar with is the idea of a single event, the loss of a loved one, a major injury. Complex trauma, which I briefly discussed earlier, contains trauma that accumulates over time as a result of repeated stress and traumatic events. For example, the experience of houselessness and displacement. Collective trauma is experienced by groups of people. This would be things like racial discrimination, genocide. And finally, historical trauma include events that are long-lasting and impact a generation or generations. Not included in this slide is vicarious or secondary trauma, which in practical terms is related to frequent exposure to traumatic stories, as we may experience kind of repeated stories of our patients that are traumatic to them. You don't necessarily have to be the one who's on the receiving end of a traumatic event. Next, we have the 4 R's of a trauma-informed approach. A system that's trauma-informed realizes the widespread impact of trauma and understands potential paths for recovery. It recognizes the signs and symptoms of trauma in patients and staff, and even if those signs manifest as challenging behaviors. It responds by fully integrating knowledge about trauma into policies, procedures, and practices. And our goal is to actively resist re-traumatization and prevent further compounding of traumatic stress for our patients. This brings me to the 6 principles of trauma-informed care. I think of this as the scaffold that we build practices on, as the how-to for trauma-informed care. First, our goal is to create an environment of safety for patients and providers. Develop trustworthiness and be transparent with our patients. Be clear with possibilities and expectations, and communicate clearly and follow up when you say you will follow up. Offer explanations in decision-making and next steps. Third is tapping into peer support networks. So let's take a test case as an example. So imagine you have a young female patient. She comes in after being the victim of firearm violence. She discloses to you that she has a history of intimate partner violence as well. For our purposes, we'll call her B. B struggles with the process of taking vitals, the process of putting the blood pressure cuff on her arm, and as a result has many, many hours within the first 24 hours of her admission where she just does not have vital signs charted because she doesn't want to wear the cuff because it feels very, very restrictive. What do you need to do to address this, right? We need vital signs to be able to take care of her, but if we're rigid in how we enact this need or policy, we may lose her participation as a result. One way to address this and how I try to approach these situations is to understand why. What happened to her? What makes this process difficult? Has the necessity of obtaining regular vitals been explained to her? Does she understand that it helps us make medical decisions? How can we partner with her? Maybe come up with a vital schedule that she feels more comfortable with. Maybe stop vitals at night so we aren't waking her up needlessly. And ultimately, we can create a plan together where we're able to get the information we need and make her feel safe and heard. This is a nice segue to our final 3 principles. First being collaboration and mutuality, leveling this power differential and partnering with patients. Empowerment and choice, which pairs well with collaboration and mutuality as well. Here, shared decision-making can be employed, and working to empower patients to manage their own care, teaching skills, creating choice when able, just as we just did in talking about the patient case B. And finally, the 6th principle is awareness of historical, cultural, and gender backgrounds. Here you can fit things in like implicit bias training, cultural humility. An example here is engaging cultural mediators when you're able, or when there's some discongruent cultural experiences between a provider team and a patient. In our test case of B, we developed a plan together, fostering this sense of mutuality, empowered her to have control in her care, and make decisions about small things that are malleable and permit this therapeutic relationship. What B was experiencing with challenges with vitals and taking off her blood pressure cuff can be seen as a challenging behavior. Some behaviors we experience in care settings may be difficult for us to understand, but actually make sense in the context of trauma. For example, aggression can come from a drive to protect oneself from further harm. Difficulty trusting others or distrust in the provider team can be a self-protective mechanism to prevent subsequent trauma. Extreme passivity or deferring decisions to others frequently could originate with a fear that boundaries have led to harm in the past and may continue to cause harm. Extreme rigidity can be an effort to maintain a sense of safety or control. This one in particular resonates with me because we often rob patients of their agency in the hospital. This lack of control can be a major contributor to re-traumatization. It can also lead to major discord between patients and care teams. For me, at least personally, in my experience, this has been the origin of many events that have had led to leaving against medical advice that I've seen is this extreme rigidity and then an unwillingness to budge from a care team perspective. We can also see self-harm behavior as a trauma response, which has been employed or can be employed to manage overwhelming emotion. The goal is to reconceptualize a lot of this behavior and recognize that there are often healthy, normal needs driving what we're seeing. They come from the need to cope and manage symptoms, to feel in control, feel safe, or find meaning in either what's happening in the hospital right now or prior traumatic events. So let's say it didn't go well. Let's say we had a major conflict with B and we need to do some service recovery. How do you approach a situation when things don't go well? So I want to leave you with this acronym LAST for service recovery. First, listen. Employ reflective listening here. Give the person sitting in front of you your full attention. Acknowledge their concern and their experience. Validate those concerns and offer an explanation of what happened. Work together with your patient to solve the problem. What would have been a better care pathway or outcome from their perspective? Identify systematic changes that prevent things like this from happening in the future. Finally, thank that individual for helping them improve your care. It takes a lot of time and vulnerability to disclose when things don't go well and work with a care provider on this. I mentioned reflective listening. So some pointers for reflective listening are to be present, try to avoid multitasking, which I know is tough to do in our busy clinic life. Reflect what you're hearing back to the patient. Pay attention to nonverbal cues. What can you surmise from their body language? Do they appear uncomfortable? Do they appear very activated? Normalize, or all behaviors have a cause and a function, as I mentioned, and normalize the emotions and the experience. It may be manifesting in a way that is foreign to you, but these emotions are no different from yours or mine. Another segue from challenging behavior is often these things can get integrated into documentation. How many of you have seen stigmatizing language used to describe a patient that you cared for? How does it make you feel? How does it impact your impression the second you walk into a room because you've already read a number of things about this person in the chart? Charting is an opportunity to pass on an unbiased or a biased perspective on the patient you're caring for, depending on the language you use to document. While there are suggested phrases, the best rule of thumb is to stick to the facts. Avoid comments like hostile or failure to comply or frequent flyer, because these can bias providers that will care for this person in the future. Personally, when I document trauma patient histories, I make an effort to stick to the injury and the mechanism. I don't talk about who shot who. I just say there was a gunshot wound. I want to emphasize that this is separate from documenting safety concerns. If a patient has been harmful or at risk of being harmful to staff, this should most certainly be documented and passed on to future providers. The care plan function in Epic, for example, is a great place to document this information. So it's accurate, it's actionable by other providers and alerts you when you open someone's chart. By no means should you feel unsafe and feel like you cannot pass that information on to other people. Trauma-informed care is a systems approach. I'm going to go through a tiered kind of schematic for trauma-informed care and how we hope to integrate it in Harborview. So it's enacted in a tiered fashion. This base blue level at the bottom are universal precautions for all comers. This green level up at the top is targeted trauma-informed care for patients with risk factors or patients who are demonstrating elevated distress related to their hospitalization. Finally, at the peak here, we have clinical and treatment trauma-informed care, which centers on patients with severe and escalating distress. I think of these two base levels as focusing on prevention and this top level focusing on treatment. So who are we targeting with universal trauma-informed care? Essentially everyone, from patients who are newly admitted but are overall resilient, have good coping strategies, resources, and support. This should be sufficient. The goal essentially is a first line of defense and to modify the patient experience broadly. Interventions here are ensuring active pain management, managing distress when it presents itself, providing clear, consistent information, and providing choice when appropriate, similar to how we did in our case, and listen and clarify any misconceptions about care or plans. Universal screening for PTSD and depression also fits into this particular tier. This is now mandated for all trauma centers in the United States at this point in time. Next, we'll address this middle green bar, which is targeted trauma-informed care. Targeted trauma-informed care is focused on patients who demonstrate acute stress reactions or have risk factors indicating potential for long-term challenges. Our goal here is to assess, prevent, and reduce development of further traumatic stress symptoms. This group of patients has shown us they're at risk, and our goal is to reduce future burden. Interventions here are to address the immediate emotional distress. On intake of patients as well, you can assess for risk factors or signs of acute distress. If something that you notice, like nightmares, an exaggerated startle response, anxiety, or the inability to concentrate begins to present itself clinically, take note and flag this person as someone who has a higher level of need. Involve mental health specialists as appropriate. This is where the benefit of rehab psychology, it could not be understated. So engage them if you have access to that team. You can also engage peer systems for further support. An example being a hospital-based violence prevention program, like our VIP program. Finally, we go to the top of the pyramid, which is clinical and treatment trauma-informed care. So who is targeted by this particular tier? It's those who are experiencing escalating symptoms or have other emotional challenges that are impacting their ability to engage in care. These are the patients who are at high risk for prolonged stress responses and will likely need longer-term support. So our goal here is to identify and treat the traumatic stress. Interventions here are greater escalations of mental health care, determining the next step. Do they need a psychiatrist to initiate medications? Do they need outpatient referral for ongoing psychologic or psychiatric support? Or do they need greater involvement from the rehab psychology team or other services to help them get through this hospitalization? Kind of summarizing the earlier section and then the systematic section. Trauma-informed care incorporates institutional policy as well as individual actions to impact the entire hospital experience. So true reform is much larger than an individual training, but it incorporates support services, access to care, support for staff, which are larger institutional objectives, right? So what I want you to take away is to appreciate that traumatic stress can manifest clinically, reconceptualize some of these challenging behaviors as trauma responses, focus on centering your patient and the family in care, actively address risk factors for poor psychiatric outcomes if you see signs of escalating stress, and advocate for care and support for staff so that we can do all of these things for our patients. On that note, I'm going to jump to vicarious trauma. So vicarious trauma is the result of a normal empathic response of working with trauma survivors that as a result changes your worldview and can influence other aspects of your life. This can include feelings of over obligation to work, feeling like you're letting someone down, becoming more cynical as a way to remove yourself from traumatized individuals, and increased fears and concerns about you or your family's safety, and other similar responses from this constant exposure to traumatic stories. It's important to note that this can also lead to post-traumatic stress disorder. In healthcare, we bear witness to many traumatic stories, especially in the care of our patients at Harborview. Repeated exposure to these stories can lead to the development of post-traumatic stress. Vicarious or trauma or secondary trauma results from these repeated exposures. While the traumatic event may not be directly happening to the individual, they have repeated indirect exposures that can have an overall similar effect. About a year ago, Laura Vandernoot-Lipsky, who was a visiting speaker in 2023 with the Trauma Stewardship Institute, has an amazing TED Talk where she talks about her experience with the cumulative toll of repeated exposure to suffering and hardship when she worked as Harborview staff. The TED Talk is called Beyond the Cliff, and I think it's a great illustration of how these events and this experience can affect staff directly. I recommend it. And it's pretty easy to find if you Google her name. Whoops. One thing that she included during her presentation was this map for a day in the life, essentially. It offers suggestions for moments of mindfulness and intentionality that can be integrated in small pieces. This is way too small to appreciate on a PowerPoint slide, but it's a nice illustration that you can easily download on the website. And it's a way to kind of take small moments for yourself because we all have very limited time to work on taking care of yourself in the care of our patients. This is the link for the download. I wanted to briefly go over some faculty and staff resources. So we have some of this infrastructure in place for staff support to offer help in times of need. If you or someone you know is struggling, these are a list of resources that are available through the UW or Harborview system. So critical incident stress debriefing will be rolling out at Harborview and be a resource for impactful, stressful hospital events. I know Shelley Weishman has worked extensively on this. You're also able to reach out to ethics with a consult or even a moral distress consult to discuss the challenging patient situation or provider-patient situation. The EAP is the Employee Assistance Program through Washington State and includes services for employees and their families that include counseling, work, and financial resources. Spiritual care is also available for provider crises, and the Employee Mental Health Support Program is a clinic run out of Roosevelt Clinic available to employees as well. And the GME office offers counseling, and this QR code is a link to the GME wellness page for those residents out there. I see a question from Crystal. You can go ahead. Okay, we can come back to that. I wanted to talk briefly about moral injury as well. So moral injury is the psychosocial impact of transgressing your own deeply held moral beliefs and values. So for me, this manifests when a patient's asking you for a moment more of your time with a door handle question, but you need to keep moving because you already have 2 patients waiting in other clinic rooms. Or when a patient has a question on morning rounds, but you have 20 more patients to see before staffing, so you need to walk out of the room. This is a photo and a link to a New York Times Magazine article that illustrates 2 provider stories, a rheumatologist and an emergency department physician, who kind of illustrate their struggles with working with insurance and working with limited resources in their hospitals. My point here is our systems aren't designed to do this work. We're often trying to give this level of care, but where we work limits what we can do. I know that I struggle to practice trauma-informed care when I'm rounding on a large patient census in the early hours of the morning on our trauma service. There are some ways to combat some of this decision fatigue and cognitive overload that results simply from our healthcare system. We make impactful decisions in the care of our patients all day, and we really need to prioritize conserving that resource. So if you can, let go of non-essential decisions. Try to reduce interruptions during times of deep work. Turn on your phone on silent if you don't have clinical commitments, or commit fully to taking that break and spending that time effectively and recharging. Try to allow sufficient recovery time. This is a tough one. I have experienced our resident call schedule and also have seen many attendings with similarly tight schedules. Both as an institution and on a personal level, we need to allow for recovery time between times of intense work and make that a priority. Be mindful of false urgency. Someone else's inability to plan ahead is not your emergency. On that note, be intentional about what you ask of yourself and others. Assess what is a realistic ask before you extend that invitation. And maximize times when your mental acuity is high. Maybe this is early in the morning before a busy clinic day, or if you're like me, later at night. Take note of your own patterns and capitalize on them. Similar to Maslow's hierarchy of needs, we have a physician hierarchy of needs. Again, we are limited by our environment. I'm going to go through the bottom few tiers, and then we'll talk about the top of this pyramid. So stage one are basic needs. So I'm hydrated. I have access to food, time to eat, and enough sleep, and no struggles with any mental health issues. Stage two is safety. My job's secure, future predictable, and I'm physically safe. Stage three is respect, a basic level of mutual respect and inclusion. Family time is respected. I'm not hassled by IT, the electronic health record, or bureaucracy. If I didn't lose you in the earlier stages and you work in direct patient care, I most certainly have lost you now. So our goal is to be at the pinnacle of this pyramid, right? Stage five. I have the time and autonomy and resources to heal patients and the time to think and contribute. I would argue that the majority of providers in healthcare can't operate at this level based on the hospital-built environment, the EHR, and the degree to which our workforce is pushed to our limits. How could we reframe some of these barriers? This is from Stanford University. It's the Stanford Model of Wellness. And it really illustrates that we can really only be as effective as our system allows us to be. So in the Stanford Model of Wellness, this is the foundation to reach professional fulfillment, according to this model. Notice personal resilience is not the only part of this foundation. This red portion is the responsibility of the institution. They must take responsibility for culture of wellness and an efficiency of practice. For our institution to be truly trauma-informed and our staff to be able to practice trauma-informed care, we need the support of our health system. We need an infrastructure for wellness so we don't have residents that can't get past stage one in the physician hierarchy of needs. We need efficient systems and realistic schedules and a safety net for the staff that need an extra hand. The truth is a whole system must shift to become truly trauma-informed as a whole. The hope is that this instruction will reach all manner of staff at Harborview so that we can weave it into care delivery as well as institutional policy as a whole for the hospital. We have a long way to go for that to happen, but this is our first initial step. What we have done so far is train the University of Washington general surgery residents, as well as one nursing training session. This was all completed as part of the trauma-informed care pilot series, where we did the first rollout of the trauma-informed care curriculum to trauma centers across the nation. At this point in time, they're regrouping and getting the feedback and going to send out a rehashed curriculum. Next, we're hoping to tailor training to different providers and provider work groups. This would include staff like food services, environmental services, security, as well as extending these trainings to the rest of Harborview provider staff like nursing and physicians. Our goal is to have quarterly training sessions. And I guess this is also a big goal of mine, is to conceptualize what it looks like to have trauma-informed operating rooms and operating room services. Thank you so much for your attention. If you're interested in this work, please feel free to reach out to Dr. Biscard or I. Our emails are listed here. We're looking forward to collaborating further as we work on this project. I think there are many ways that we can take this curriculum and modify it to be even better for our patients. And I want to extend special thank yous to Paul Carter, Shelley Weishman, Amy Sarasota, Erica Biscard, Rebecca Main, Annie Chipman, Arvin Argavan, and Maggie Loyett, who have just been so valuable in this curriculum and getting this through the planning stages. Thank you very much for the opportunity to present, and I can take any questions.
Yeah. Dr. Hernandez, thank you again for your great talk today. I apologize for being a little bit late with Zoom log on, and Dr. Biscard as well, both for your work in this. We do have a time for this. Is Matthew Cazier with Ethics. We do have time for a few questions if anybody has any right now. I think Dr. Hernandez, if you could stop sharing, that might also, or carry your, that might show up, see if anybody else is on there. Okay, great. And Dr. Hernandez, can you just describe how you are envisioning this beyond the OR and at Harborview with your work into the community, how that interface, you mentioned Paul Carter and his group, who does interface with the community, how this also will interface into the future with that?
Part of our plan to work on, so a big portion of this curriculum, like the whole, a third of it essentially focuses in on community perspective. Paul Carter has been so helpful for this particular portion. I think our goal is to reach out to some community organizations and see if they have speakers that would be interested in speaking to our group who have been patients at Harborview who are from marginalized communities. There are many, I've already been approached by a number of people who've been in these sessions who have ideas for people to reach out to, which is great. I'd like to see kind of LGBTQIA representation here, definitely, as well as someone from the houseless community represented here, and someone who has lived experience with substance use. I think would be kind of three main priorities for me to integrate into this rotation, because that really, that's a good portion of our patient population. So that's how I envision it going forward, I think, through reaching out to community organizations as well as kind of channeling through people who are interested in working on this who have someone in mind.
Great. And if anybody has any other questions for Dr. Hernandez at this time? Oh, there's one in the comments there, the chat rather. Do you see it? What kind of buy-in pushback have you run into given how resource intensive the training may be? ? I imagine managers may not have the option or desire to free up staff for even a few hours for the training or discussion.
Thank you, Dr. Orozco. So we actually haven't had much pushback. I think one thing that really helps is that this is an American College of Surgeons objective, and the ultimate goal is to make this a requirement for trauma centers. And as that comes to fruition, I think that we have, we have pretty good backing there to say that this will need to be a priority. This does really affect the form that this training takes, right? Like in-person training for 3 hours is actually pretty resource intensive, especially when you consider how so many things have gone to Zoom. And this topic, in my opinion, I need to be more flexible about this, but is best served when you're able to communicate in person. I think, the main experience that I've had with this is working with nursing. So nursing was actually very accommodating in helping us recruit a really good pilot group. And when I had initially presented to them, many of them actually seemed open to the idea of allowing nurses to do it as part of a work shift. I don't know how that will pan out in reality, when we start asking for that time, but it's been surprisingly well received. I guess not surprisingly well received. It's been surprisingly fewer barriers than I thought there would be.
Anybody else? Does anybody else have a question? Well, Dr. Hernandez and Dr. Bisgard, both of you, thank you very, very much for your work. And again, Alex, I really appreciate you coming to the meeting today and presenting this great work. And I think with the backing of American College of Surgeons and other leaders, we're going to see a lot more training in this field and certainly information that we all need. So very much appreciated. And there's some suggestions in the chat for reading as well, I see from people.
I'm taking notes.
Okay, we all are. All right. Well, thank you again. Thank you, Dr. Hernandez. I really appreciate it.
Yeah,
thank you all for logging on. Great. Thank you.
Bye.
We'll see you soon.